Hello and welcome to my off-thal teacher. I have already made a lecture on penetrating keratoplasty, so let's talk a little bit about lamellar keratoplasty or component keratoplasties. Okay, so these are short lectures divided into three parts. So let's begin. What is lamellar keratoplasty? So we talked about PK, right? Total penetrating keratoplasty, which means that the whole thickness of the cornea is transplanted, as you can see here. Okay, that's the layers of the cornea and epithelium, stroma, desme, endothelium, and just before the desmoid membrane is a Duas layer or the pre-desmoid layer. This is important to know because we are talking about lamellar keratoplasties. So lamellar keratoplasty definition, it is the selective removal of diseased corneal tissue and its replacement by healthy donor corneal tissue. Broadly classified into anterior and posterior. Anterior includes replacement of the anterior corneal layers. That includes Bowman layer transplant, superficial anterior lamellar keratoplasty, that is up to 50% of the corneal stroma, deep anterior lamellar keratoplasty, that is up to 80% of the corneal stroma. Then we have the posterior lamellar keratoplasty or endothelial keratoplasty. That includes desmoid stripping endothelial keratoplasty, desmoid membrane endothelial keratoplasty. Okay, so desmoid stripping endothelial keratoplasty, DSEK or DSEK, that is automated endothelial keratoplasty. It basically includes a part of the posterior corneal stroma, the desmoid layer, and the endothelium. That is DSEK. And DMEC includes only the desmoid layer and the endothelium, right? So that's the posterior keratoplasty. Just briefly about the history. So the concept of lamellar keratoplasty was introduced in the 2nd century AD by Galen. Okay, so the blue arrow shows how advancements happened in anterior lamellar keratoplasty, and the orange arrow shows the posterior lamellar. So in 1886, von Hippel performed the first lamellar transplant using a rabbit cornea. 1886. 1914, Elchnik first performed the anterior lamellar keratoplasty. 1965, Brown discovered the deep stromal dissection plane. Now, once this happened, several techniques were tried to reach the deep stromal plane for anterior lamellar keratoplasty. They tried to inject air, they tried to hydrodelaminate, they tried manual dissection and viscoelastic substances. So finally, in 2002, the anterior lamellar keratoplasty was revolutionized when Anwar invented the big bubble technique, which we will be discussing in this lecture. Talking about posterior keratoplasty, now these were a little more recent. So in 1956, Tillett performed the first endothelial keratoplasty. Then 1998, Melis described the concept of posterior lamellar keratoplasty. 2006, Melis developed DMEC. 2008, the Busin glide was invented. And 2014, PDEC was described. And this is the most recent thing in endothelial or posterior lamellar keratoplasties. So this lecture is about mostly about deep anterior lamellar keratoplasty. Because it is the most popular anterior lamellar keratoplasty. Bowman layer transplant and superficial anterior lamellar keratoplasties are not that widespread. So we'll be talking about DALK, okay, or deep anterior lamellar keratoplasty. So it is very important and it's going to be very useful if you try to remember the layers, of course, and the thickness of each of these layers of the cornea. So epithelium is 40 to 50 microns. There is no, transplantation as such. Epithelium grows on its own. Then there is a Bowman's layer, which is 15 microns. The stroma is 440 to 460 microns. Dua's layer or pre-desmet layer or PDL, as I have abbreviated in my lectures, is 10 to 15 microns. Desmet is 10 microns. Endothelium is 10 microns. Okay, so keep this in mind, and things will be easier, and you will have an idea about how thick an anterior corneal graft is versus how a posterior corneal graft is. Okay, so when the pathology involves anterior corneal tissue, that is epithelium, Bowman's, and stroma, sparing the desmet and the endothelium, it is known as anterior lamellar keratoplasty. So superficial ALK is when the pathology is in up to 50% of the stroma, and deep ALK when the pathology is in up to 80% of the stroma. So this is deep ALK, right? Up to 80% of the diseased stroma is removed and replaced with healthy tissue. So what remains? A bed of residual stroma, Descemet membrane, and endothelium remains. That is the patient's or the recipient's own. Indications, just like PK, there are tectonic, optical, and therapeutic indications. Tectonic means something that is for structural support. So you understand desmetocele, PMD, advanced terian, sterile Moran ulcer, and peripheral corneal meds, where the integrity of the cornea, the structural integrity of the cornea is compromised, constitutes tectonic indications. Optical indications when there is a high degree of irregular astigmatism, such as in keratoconus, scar, corneal dystrophies, degenerations, post-refractive surgery ectasia, and advanced pterygium, right? So that is optical to correct very high irregular astigmatism. And of course, therapeutic. Therapeutic is basically to remove infected or diseased corneal tissue, such as in post-keratitis, dermoid, inflammatory masses, and a perforated cornea. And of course, there are cosmetic indications where just the patient just wants to remove an opaque white cornea. Absolute contraindications is unhealthy endothelium, pre-existing break in descemet or a scar in descemet membrane. Now these are contraindications because even if you remove the anterior tissue, the posterior corneal tissue is still diseased and the pathology, the visual outcome will not be good. So these are contraindications. If the endothelium is unhealthy or if the descemet membrane is unhealthy, you perform a posterior lamellar keratoplasty. Okay. So the Anwar's big bubble technique. Now what I'm going to do is I'm going to talk about the surgical steps first, and then I'm going to show you a video and that will help clarify most of the things. So a partial thickness trephination is performed. Okay, this is basically a trephine. Okay, it has a blade, a circular blade, which cuts the cornea, right? So all the trephines come in various sizes and depths. So this one's about 300 to 400 micrometers deep. Okay, then all this is being done on the the recipient eye. Okay, a partial thickness trephination so as to remove the stroma. So trephination is done and the trephine helps in making a groove of about 300 to 400 micron depth in the stroma. That is the amount of stroma that we want to remove. A bent 30 gauge needle with bevel down is inserted into the trephination groove, advanced deeper into the corneal stroma, remaining parallel to the DM. If you go this way, you're going to puncture the DM. Okay. The tip of the needle is aimed towards the paracentral cornea. So once we are well within the trephination groove, we inject air from this syringe with some force. Okay. So the air is injected and you can see the descemet is separating. Okay, and the air, as more and more air is injected, the air bubble is being formed and this is known as the big bubble. So entry of air, now air always follows a reproducible path. Okay, so entry of air into the pre-descemet plane is marked by a sudden large white bubble which is outlined by a band, and this is known as type 1 bubble, seen in 80% of the cases. So this is the plane in which that air bubble enters, usually in the pre-descemet, between the pre-descemet layer and the posterior stroma. That is the big bubble. Sometimes what happens, a type 2 big bubble is formed. That is when there is intra-descemet membrane entry of the air. That is a type 2 bubble, which is not a problem because at the end of the surgery that we are going to get rid of that type 2 bubble because we're going to place air in the anterior chamber. So when the border of the bubble, that type 2 bubble that I'm talking about is usually formed when the air enters intra-DM, whereas type 1 bubble is when the air enters above DM, rather above the pre-descemet layer. Okay, that's the difference between type 1 and type 2 big bubble. Type 1 is seen in 80% of the cases and type 2 is seen in the remaining cases, and sometimes you also have a mixed type 1 plus type 2 bubble. So this bubble is enlarging. Okay, we've made a type 1 bubble, we've injected air in the pre-descemet layer, right? And a big bubble is created. And when that air bubble is about the size of the trephination groove, further air injection is stopped. Then, now that you have separated the deep stroma from the underlying desmet and endothelium, what do? You have to cut that separated stroma. So you make a little cut in the anterior stroma, okay, with the help of a lance tip. And then that obviously the big bubble is ruptured. You fill that space with viscoelastic. That's what they're doing here. And they're basically cutting the anterior corneal stroma that has been demarcated with the help of a bubble. Then it is pierced. Is injected into the space occupied by the bubble. Stroma is separated from the underlying DM and removed in parts. So basically, when all of the stroma is removed, what is this structure that is remaining? This is the desmet membrane. Remember, the desmet membrane is a transparent structure. So let's look at a video now, okay? Of course, the donor preparation. So finally, the donor button is sutured in place. So see, this is what the the once the stroma has been removed, this is what the recipient bed looks like. This is the transparent desmet membrane covering the anterior chamber. This is the button that has been prepared already. What is this button consisting of? It is consisting of the anterior stroma. Okay, 50 to 80% depth. And it is going to replace the stroma that we have here removed. So the donor button of desired size has been punched, and the DM, that is the desmet membrane in that donor button, has been stripped off. So now the donor button is ready. The DM has been peeled off. This is, showing the DM being peeled off such that only the stroma remains, and that stroma is replaced over the existing recipient DM bed and sutured just like in penetrating keratoplasty. So this is what the post-operative outcome looks like. So just coming on to the video now, they have marked the trephination area. That's the trephine, making the groove in the stroma up to a depth of say 300 microns. A side port being made to enter the anterior chamber. Air is injected into the anterior chamber. That is the big bubble, type 1 big bubble being formed. See, it is inside the stroma. That is why it's white, and it appears explosively as the air is pushed, right? That's the type 1 big bubble. Next, a groove is made. That is the cut in the stroma. The air is released. Visco is injected in the plane between the stroma and the predesmet. That's the blunt corneal scissors. Why blunt? Because you don't want to damage the underlying desmet membrane. Blunt corneal scissors being used to remove the stroma in 4 quadrants, or the divide and conquer technique. And now you can see the underlying desmet membrane, the bubbles below it in the anterior chamber. That's the button being placed and nicely sutured just like in PK. So that was the procedure. Coming on to the complications of DALK. So intraoperative, one can perforate the underlying DM, and in that case, one may need to convert to penetrating keratoplasty. So the good old penetrating keratoplasty is already there to the rescue. Poor stromal dissection. Now, even the donor stroma has to be dissected nicely. I have not shown the donor preparation here. So donor stromal dissection has to be proper. The recipient stromal dissection also has to be proper. So it requires more skill than a penetrating keratoplasty. Pseudo anterior chamber due to desmet detachment. Of course, if the desmet detaches, then you can have a second anterior chamber, right? In the already existing anterior chamber. And anterior subcapsular cataract. Why? Because we are going to fill air into the anterior chamber, which can come in contact with the lens and cause a cataract. Okay, so that's the intraoperative. Postoperative complications include persistent epidefect, suture related problems, neovascularization, graft failure, graft rejection, graft necrosis. We have talked about graft failure and graft rejection in my presentation on penetrating keratoplasty. Infective keratitis, rare. Interface problems. Now, interface problems are present in cases of all lamellar keratoplasties. When you're doing a penetrating keratoplasty, you are transplanting the full thickness cornea. So there is no interface. There is just a graft post junction. Whereas when you're doing a layer by layer keratoplasty or a lamellar one, there is an interface, right? For example, in case of DALK, the interface is between the donor stroma and the recipient descemet membrane, right? So that is a potential space. Whenever there is a potential space, one can have debris in it. It can undergo opacification, vascularization, or even wrinkling. So that's a postoperative complication, interface problems. Epithelial ingrowth, recurrent primary disease, for example, usually in case of herpetic eye diseases, it is seen herpetic keratitis. One might face a recurrence of the primary pathology, and of course, corneal astigmatism, because we are, after all, adding some amount of stroma, right? It's not a posterior lamellar keratoplasty. It's a deep anterior lamellar keratoplasty, where invariably some amount of stroma is still being left. So that's the post-operative complications. Uret-Zavalia syndrome, I mentioned it when I was talking about PK. So basically, you have to know about it because it might be asked in your viva. So historically, it is defined as a fixed and dilated pupil following PK for keratoconus in patients who receive mydriatics. DALK is the second most common cause after penetrating keratoplasty. Why it happens? Air has been left in the anterior chamber, a full bubble is left in the anterior chamber, and one has used a mydriatic, right? So basically, a pupillary block sort of thing happens, and pressure rises. So 7.5% incidence with IOP rise after the surgery. 20% mannitol post-DALK may be helpful to reduce the intraocular pressure. And if maybe sometimes what happens is that, even viscoelastic can cause this condition. So you might have to do an AC wash and reformation with an air bubble in such cases. Now, all of these lamellar keratoplasties are compared with the gold standard, the existing age-old gold standard penetrating keratoplasty, right? Well, be it DALK, be it TSEC, be it endothelial keratoplasty, that is DMEC. So let us just compare. So endothelial rejection is not happening because we are not touching the endothelium in DALK, whereas it is a problem in PK. Structural integrity of the globe preserved in DALK, not preserved in PK. Why preserved in DALK? Because the tough descemet membrane is not being touched. Okay. Visual recovery sooner in DALK compared to PK. Learning curve is longer, steeper compared to PK. Special instruments required in DALK compared to PK. Interface related problems I already explained. Suture removal can be performed sooner in case of DALK, and complications such as suprachoroidal hemorrhage, astigmatism, endophthalmitis are rarer in DALK when compared to PK, right? So that's a comparison. Now, femto laser assisted DALK. This is something new. Here, basically, the dissection of the stroma and channel formation for needle placement and big bubble formation are pre-decided in the femto laser machine. And all that job that we were doing manually is done by the femto laser. That is why femto laser assisted DALK. Okay. Plus, it uses zigzag laser cuts between the donor and the recipient edge. So that allows a very nice tissue acquisition. And of course, sutureless DALK is also possible because the tissue acquisition is so nice, one might try omitting the sutures. So this is also a more recent thing, right? So you should know about it. So that is it about deep anterior lamellar keratoplasty. Next, subsequent lectures would be about posterior lamellar keratoplasties. Thank you for watching, and please do continue watching.